And it's 8 o'clock, so I suggest that we start our webinar. Today we will focus on the anatomy of paranasal sinuses and skull base, and there are 3 presentations today. I will start with the basics of surgical anatomy of the paranasal sinuses. Then Dr. Valentin Tomatic will start with the surgical anatomy of the skull base, and we will end up this session with talk of Professor Roberto Maroldi on radiological anatomy. So I'm going to share my screen and start my presentation. So my name is Clementina Avzeva. I work in Amsterdam at Amsterdam University Medical Center in the Netherlands. And I'm really excited to start this webinar with my talk on surgical anatomy of the paranasal sinuses. I would like to send my special thanks to Dr. Heide Adriansen for his help in preparations for this talk. In the beginning, I would like to start with a little bit of a zoom out and first to focus on the structures that surround paranasal sinuses, structures that we have to keep an eye on while performing the surgery. And then we will go through anatomical structures that are located intranasally and their variations that we have to be aware of. Before we start, I would like to emphasize that what we see in the books and what we see during sinus surgery are 2 different things. And while endoscopes provide us invaluable benefits, such as that it allow us to perform really extensive surgeries on paranasal sinuses and skull base without any damage to the external structures and any cosmetic defects, it provides us great resolution. It allows us to zoom in and zoom out depending on the goal of our surgery, and also allows us to look around the corners, for example, into the maxillary sinus or into the frontal sinus. It also provides a limited field of view and the angle of view. What I mean is that when we are looking through the endoscope, we have to keep an eye on the angle that we are using. And that the same structure with a 0, 30, or 45 degree scope will look quite differently. Additionally, when we're looking with a 0 degree scope, we're moving in the direction of the center of our field, whereas when we're looking with a 45 degree scope, we cannot actually see the direction in which we are moving our scope. We have to be aware of it while performing the surgery. And another thing that's during the sinus surgery, everything is wet, pink, and sometimes bloody. So it's quite easy to confuse one structure for another. And my advice would be is while you're performing the surgery is never to stick to one spot and look only to it, but either to create a more dynamic view, a dynamic feeling, to make sure that where you're looking at, where you think you're looking at is actually where you're looking at. So let's start with a little bit of a zoom out and pay some attention to the structures that are surrounding paranasal sinuses. If we start anteriorly, the first structures are orbits, which are separated from paranasal sinuses by thin lamina peperacea. Anteriorly, there is also a nasolacrimal duct, which is located right anteriorly to the uncinate process, and infraorbital nerves that usually run in the inferior wall of the orbit. Moving superiorly and posteriorly, the next structure is the skull base. Anterior skull base is quite thin, and it's what's also really important that there is a structure called lateral lamella. So this is the olfactory cleft anteriorly. This is the cribriform plate, and this is the lateral lamella. And this is a very thin spot in the skull base that's quite prone to cerebrospinal fluid leaks. If we move posteriorly, then the skull base becomes more dense, and posterior skull base is harder to damage compared to anterior skull base. Moving even more posteriorly, there you have sella-turcica with pituitary glands, and some important structures in the sphenoid sinus, such as optic nerves and optic chiasm, internal carotid artery, the second branch of the trigeminal nerve, and the Vidian canal with Vidian nerve. The surgeries that we are performing are done on the lateral nasal wall. So the medial nasal wall is formed by the septum and the lateral nasal wall by inferior, middle, and superior turbinates. When we insert endoscope in the nose, then we have to be aware that superior turbinate is actually located not superiorly to the middle turbinate, but rather posteriorly to it. And that superiorly, medial and superior turbinates fuse, forming the conchal plane. Conchal plates, and that's important to keep in mind when you're working on the skull base, that here really superiorly you cannot use turbinates as landmarks anymore. Intranasal cavity is covered by respiratory epithelium, except for superior part of the septum, cribriform plates, and superior turbinates, which are covered by olfactory epithelium. Most of the structures of the lateral nasal wall are formed by ethmoid bone, which has crista galli intracranially, and which separates intracranial contents from intranasal contents by cribriform plates, which is called cribriform because of small holes that are created by fibers of the first cranial nerve that penetrates the skull base. Then there are two ethmoid labyrinths on each side and a perpendicular plate that forms the superior part of the nasal septum. Labyrinths are formed by middle and superior turbinates and ethmoid cells. And laterally to each labyrinth, there is an orbit that's formed by orbital plate or lamina peperacea, a thin bony wall. Embryologically, there are 5 lamellas on the lateral nasal wall. And lamellas are basically, if we remove all the ethmoid cells, then there will be 5 thin stripes left on the lateral nasal wall. They're really important for our orientation during the surgery. The first lamella is the lamella of the uncinate process. The second lamella is the lamella of bulla. The third lamella is lamella of the middle turbinates. The fourth is lamella of the superior turbinates, and sometimes there is a 5th present lamella of the supreme turbinates. We will move through the lamellas one after another. So the first lamella is lamella of the uncinate process. We're looking now into the right nasal cavity. This is the nasal septum, right middle turbinates. And this is the uncinate process. As we have mentioned before, anteriorly to the uncinate process, there is the maxillary line. That's the protrusion of the nasolacrimal duct. Uncinate process has 2 parts, vertical and horizontal. Vertical part of the nasal, of the uncinate process can attach either to the orbits, to the skull base laterally or medially. Horizontal part of the uncinate process is attached to the lateral nasal wall superiorly to the superior attachment of the inferior turbinates. And the natural ostium of the maxillary sinus is located behind, is hiding behind the uncinate process. What's important to realize is posterior inferiorly to the uncinate process, that's posterior fontanella of the maxillary sinus. This is a wall that's formed only by mucosa of the intranasal mucosa and a layer of mucosa in the maxillary sinus. And sometimes there is a hole in there. And this is an accessory ostium of the maxillary sinus, which might be confused for the natural ostium of the maxillary sinus, which is actually located more anteriorly and superiorly, as we have discussed before. It's hiding behind the uncinate process. So if you see this during the surgery, please don't confuse it for the natural ostium and just locate the natural ostium and combine these 2 together. So this was the first lamella. Moving to the second lamella, lamella of the bulla. So again, we are looking at the right nasal cavity. This is middle turbinate. This is uncinate process, and this is bulla ethmoidalis. So it's a anterior ethmoid cell that's located posteriorly to semilunar space. Hiatus semilunaris, that's here, and it's called this way because it has a crescent shape. What's important is that between the first and the second lamella, so between the uncinate process and the lamella of bulla, this is the frontal sinus drainage pathway. So moving to the next lamella of the middle turbinate, this is lamella number 3. Middle turbinate is not just a structure that hangs into the nasal cavity. It has an interesting geometry with 3 parts: vertical parts, horizontal parts, and basal lamella. This is vertical parts, this is basal lamella, and this is the horizontal parts. And basal lamella is not necessarily a simple line. It can have quite a funny shape because of pneumatization of anterior and posterior ethmoid cells into the basal lamella. Basal lamella separates anterior ethmoid cells to posterior ethmoid cells. So if we go through this structure, through basal lamella, we will be in the posterior ethmoid area. Middle turbinates might sometimes have some anatomical variations. For example, it might be pneumatized. The whole body of the middle turbinate might be pneumatized, or just superior part, and then it's called cell of Grunwald. Or it can have a funny shape when it's curls, when it creates a curls towards the nasal septum. So be aware of these anatomical variations so that they won't confuse you during the surgery. Then we move to the fourth lamella, which is superior turbinate. So here we're looking into the left side of the nasal cavity. This is septum, this is middle turbinate, the third lamella, and this is superior turbinate, the fourth lamella. And sometimes there might be supreme turbinate. Posteriorly to the superior turbinate, there is a natural ostium of the sphenoid sinus, which is about 2 centimeters from the nasal choana. So this is the natural ostium. While opening it, be aware that it's better not to be too enthusiastic in opening it downwards, because here runs the posterior septal branch of the sphenopalatine artery. And if you are being too enthusiastic and cut through it, it might create quite an unpleasant bleeding during the surgery. An important anatomical variation to be aware of is onodicell. This is the pneumatization of posterior ethmoid cell into the sphenoid sinus. That's how it looks on the CT scan. And onodicels are in a very close proximity to optic nerves. So please be aware of it, because when you're going for sphenoid sinus, either due to polyp surgery or because you are creating a transsphenoidal approach to the pituitary gland, be aware of it and make sure that you're in sphenoid sinus when you're thinking you're in a sphenoid sinus. Onodicels might be bilateral or unilateral, and this is an endoscopic view of this patient. And here you can see the onodicell, the sphenoid sinus, and the optic nerve. Moving forwards from the posterior skull base now back to anterior skull base, we have already mentioned lateral lamella. So here we are looking at the right nasal cavity. This is septum, middle turbinate, bulla, orbit. This is cribriform plate, and this is lateral lamella. And Keres classification separates lateral lamellas into 3 types, depending on how long it is. And type 2, between 4 and 7 millimeters, is the most common. However, apart from length, what's also important is its slope. When it runs vertically, like here, while you're performing anterior ethmoidectomy, it's actually really hard to accidentally poke through the lateral lamella. However, when it has a certain slope, that becomes easier. So this situation is way more dangerous than that. Another important thing to be aware of, that skull base might be asymmetrical left and right. And I think it's especially important when you're performing the drive-through surgery. So you need to have a look at a CT scan beforehand to make sure, to be aware of the fact that skull base left and right will be looking different in some patients. Next important structure is anterior ethmoid artery. It's important because this is a branch of ophthalmic artery, and when you cut it during the surgery, it jumps back into the orbit, creating a nasty bleeding in the orbit, which leads to the increase of intraocular pressure and damages optic nerve and might lead to blindness. To locate it preoperatively on the CT scan, you look for a pointy nipple sign, and sometimes it's located quite safe and covered by a bone. However, there might be a bony dehiscence, or it might be hanging on a mesenterium. So you really want to be aware of where is your anterior ethmoid artery and whether it's a safe variant or not. During the surgery, you can locate it by its direction. It moves from posterior laterally to anterior medially. And another landmarks to be aware of are that it's located between the second and the third lamella. Another anatomic variation to be aware of is Haller cell. When we perform ethmoidectomy in Amsterdam UMC, we first create opening to the maxillary sinuses, and then we look for the orbital wall. So Haller cells are important to keep in mind when you're using the same approach, because you want to make sure that you're in the orbital wall and that you have chosen a right plane for dissection, and that you are not confusing this wall for that. And the last but not least anatomic variation that I wanted to pay attention to is hanging infraorbital nerve. Because when you're performing polyp surgery, you usually do quite a lot of things with a shaver. And when it's hanging, you really want to be more careful with shaving off the polyps in the maxillary sinus. So some take-home messages. The first one is be aware of where you are, be aware of the structures that are surrounding the area that you are operating on, and always double check that where you are is where you think you are. Don't forget about anatomical variations and don't let them confuse you. And last but not least, always study preoperative scans and be aware of the anatomy of the particular patient that you are going to operate on. So this is the end of my presentation. Thank you very much for your attention. I suggest that we move to the next presentation and answer all the questions in the end.
So thank you very much, Clementina, for this excellent start and kickoff. And I am allowed to continue and hopefully will keep your attention up. So I'm really happy to be part of this webinar series about anatomy of skull base and paranasal sinuses. And as we all know, anatomy is key for any of the surgical approaches. And I'm happy to be within these excellent colleagues here tonight. My name is Valentin Tomasik. I'm from Graz, Austria, and I'm really happy to talk to you about the surgical anatomy of the skull base. When you do skull base surgery, you will encounter a lot of lesions that you enlarge your spectrum with. Most probably you will start with pituitary adenomas just because they are the most prevalent lesions that you can approach via a transsphenoidal, transnasal approach. But there are intra and suprasellar cysts, there are meningiomas of the sellar tubercle or even of the olfactory groove, craniopharyngiomas, esthesioneuroplastomas, or any other kinds of tumors that expand to and through the skull base. As you already learned in the beautiful talk by Clementina, the first steps are to get your way around in the nose, knowing your ethmoidectomies, knowing how to approach frontal sinus, and of course, knowing how to approach sphenoid sinus. Excuse me for the German, but as you heard in the previous talk, these are your essential friends, the middle turbinate, the uncinate process, and the ethmoidal bulla, your really most constant landmarks and the first steps and anatomic structures that you encounter on your way from anteriorly to posteriorly. Of course, you should be very familiar with transethmoidal routes and ethmoidectomies before you go into skull-base surgery proper. So you can also do a transethmoidal approach to the sphenoid sinus and then go further into skull base if you needed more space and wanted to have more space, especially laterally into the sphenoid sinus. Then you remove the uncinate process, the ethmoidal bulla, and all the ethmoidal lamellas until you reach the anterior face of the sphenoid sinus, and then go into the sphenoid sinus, enlarge the natural ostium with your transethmoidal route to have a big exposure of the sinus proper. Since we do a lot of pituitary adenomas and midline lesions, and I will also focus therefore in this talk on the paraseptal approach and also on the anatomy of the sphenoid sinus and skull base there. So this is really our workhorse to go paraseptally towards the natural ostium. We do this by gently deflecting the middle turbinate and the superior or even supreme turbinates gently laterally without out-fracturing them, exposing the natural ostium of the sphenoid sinus. And you already see a circular cutting punch here, all eager to enter into the sinus. But as Clementina showed you before, there are significant branches of the sphenopalatine artery that run on the inferior circumference of the natural sphenoid ostium. They may not cause a bleeding that is detrimental, but first case, if you overlook to have ruptured one of these branches and after patient wakes up from anesthesia and cuffs, for instance, then there may be a bleeding that cannot be halted just by packing. So you need to go back into surgery, which would of course be non-beneficial for the patient. And in case you do extended approaches and you want to harvest a nasoseptal flap, a so-called Haddad flap, you need to preserve these vessels in order to have vasculature for your flap. So before you do full hearty bites into the natural ostium, just take a minor incision at the inferior circumference of the natural ostium and then deflect the mucosa, including the vessels a bit inferior to be on the safe side. So going back to the natural sphenoid ostium, once you preserve the turbinate, you enter the sphenoid ostium, you try to enlarge both sphenoid ostia, then you take the posterior superior part of the septum down with cutting instruments until you expose the entire anterior wall of the sphenoid sinus, and then take it down to the floor of the sphenoid sinus in order to have a nice exposure of the sphenoid sinus. Once you are in there, you see delicate structures. The first structure you will probably cut through and dissect is the intersphenoidal septum. A very important recommendation is that the intersphenoidal septum, albeit being called intrasphenoidal, is not always attached directly at the midline, so it may also go towards laterally and thus be in close proximity to the carotid canal. So it's advised not to just tear off or torque off the intersphenoidal septum, but take really full bites and clear bites with a through cutting instruments until you reach the end of this septum without out fracturing it and thus potentially harming the carotid artery. If you then are at the level where the intersphenoidal septum is reduced, you see following structures: the sellar floor, which is your access to the pituitary gland. You can see the optic nerve superiorly and the carotid bulge inferiorly, that is the paraclinoid part of the carotid artery. And between those, depending on the pneumatization of the sphenoid sinus, you see the optocarotid recess or infraoptical recess. This is a very beautiful landmark that directly depicts you the position of the optic nerve and the carotid artery. And the lateral or optocarotid recess is in the vicinity of the medial opticocarotid recess, which is an important structure because it marks the lateral confinement of the sella, and you wouldn't want to go more laterally in order not to harm optic nerve or even the carotid artery. Down there, you see the clival region. In this case, it's not as far indented as in largely pneumatized sinuses, but inside the clivus, you can reach towards the basilar artery and towards the posterior cranial fossa, and lateral to it, you find the paraclival part of the carotid artery. And here superiorly, a very important landmark is the sphenoidal plane, because the sphenoidal plane is the first step or the first structure to resect when you want to go to extended approaches that go beyond the sellar space. As you heard previously, there is an anatomic variation that is called onodicell. And if you think you see the optic nerve and the sphenoid sinus, because in this case you see that there is a lamella that is just running over the carotid artery, and the sphenoid sinus is behind this thin bone, and this is actually still an onodicell that is pneumatizing very much laterally and superiorly almost around the sphenoid sinus and harbors the critical anatomic structure of optic nerve and carotid artery within itself. So don't mistake that for the sphenoid sinus, because the actual way is one lamella or one step further posteriorly. Talking about optic nerve and about optic nerve decompression, which is also a procedure you may want to do, you have to be aware to encounter the ophthalmic artery. And it's very important to know its course alongside the optic nerve, which is basically in a way that it is always running below the equator of the optic nerve. So on the right side, you have it from 3 o'clock to 6 o'clock, and on the left side from 9 o'clock to 6 o'clock. So if you want to decompress the optic nerve and need to incise its sheaths, it's always recommendable to go superior to the equator, not to harm the ophthalmic artery, because this really can cause major bleeding, especially if skull base is open, and also cause severe damage to the intraorbital structures and to the optic nerve, and even cause blindness of the patient. So as a little summary for the first vital anatomic structures, you may want to visualize the opticocarotid recess. This is possible with a 0 degrees endoscope once you have really opened the sphenoid sinus and resected the anterior wall and the intersphenoidal septum, so you can look from both sides. Don't be disappointed if you encounter a sphenoid sinus that is not as impressive, because the more pneumatization the sphenoid sinus took, the more those structures are displayed, and the less pneumatizations, the more flat the surroundings is. But in a normal sphenoid sinus, you should be able to see these structures. Be aware of the medial opticocarotid recess, because it marks the lateral border of the sella, the medial aspect of the parasellar carotid and the cavernous sinus, and it is inferior medial to the optic nerve. So don't go lateral to that with cutting instruments, because then you may rupture these critical neurovascular structures. Of course, you need to remove the bone in order to go into the intracranial space to resect tumors. It is very feasible to do that with drills. I just want to draw your attention briefly to a little technique that we apply, which is piezoelectric endoscopic transsphenoidal craniotomy. The advantage of this system is that you cause only small incision lines in the bone. You can harvest bone flaps and then put them back for later reconstruction. And I show you in this video that we did together with the neurosurgeon how elegantly you can cut the bone here and create an opening, a window into the sellar floor without harming the dura, because the piezo effect only cuts mineral material and not soft tissues, so the dura underneath is unharmed. And this is very nice, especially when you go for a transplanum approach, when you are close to the carotid, not to rupture these delicate structures. And then once the tumor, the adenoma, is removed, you can just put back the flap as you would do in a swinging door technique, fix it with fibrin glue, and then you have a nice closure of the defect. If you opened the bone here, in the inferior part of the sellar floor, of course, you encounter the pituitary gland region, very close to carotid and optic nerve. And here you see the optocarotid recess. If you do an extended approach anteriorly, you go through the transsphenoidal plane approach and transtubercular approach of the sphenoidal plane. And further anterior, you go from the sphenoidal plane towards anterior skull base. And there can be an opening done up to or even more than 5 square centimeters. So you can really nicely expose the dura in this part, and also go into the suprasellar space, for instance, for highly upreaching adenomas to the third ventricle, or the classical approach that is really designed for this tumor would be for craniopharyngiomas. Be aware that you don't only have the carotid artery and the optic nerves in the lateral vicinity of the sella, you also have the cavernous sinus, and most importantly, the extraocular nerves that run through the cavernous sinus, and especially oculomotor nerve can be harmed, especially when you apply pressure into the cavernous sinus if it may bleed. So be aware of the fact that those nerves are very sensitive and are also running in dural duplicatures alongside with the vessels towards anterior, towards the orbit. I don't want you to learn all these branches by heart. I can't even recall them, but it is very important. Our neurosurgeons always raise their fingers when it comes to those fine branches getting off the internal carotid artery into the chiasm and into the pituitary gland, especially the superior and inferior hypophyseal arteries. If you pull on the tumor adenoma, you may rupture those vessels, and this can cause critical failure to the pituitary gland. Or in case you rupture the chiasmatic branches to the optic chiasm, this can really cause hemianopsia or even blindness. So please be very gentle with those vessels. They are very thin and are very prone to rupturing. So never pull onto structures, but really gently dissect the tumors of the surrounding structures. And this is especially true for craniopharyngiomas that may have a prechiasmatic position, which means that the chiasm is prefixed in front of the craniopharyngioma. So you really want to dissect off the tissues and the vessels from the tumor without causing a bleeder. Another minor but still important fact is that intercavernous sinuses run across the dura in the sellar floor, which is not a problem with bleeding, but still it can cause some irritation because it's bleeding onto your scope and you may have a blurred vision. So make sure if you incise the dura to always incise it in a U shape. So you save, on the one hand, the intercavernous sinuses running superiorly, transversally in the sellar floor. And also you don't want to cause a CSF leak because here in the superior portion, the duplicature of the dura covering the sellar and the dura covering the sellar floor is attached at the sellar tubercle, and here you're very close to the intracranial space and can rupture the diaphragm, which is a very thin part of the dura in this region. So use the anatomy as your friend, as your helper, use it as your practical guidelines alongside the navigation that you may use. You have to interpret the relationship of your lesion, of your tumor towards the critical neurovascular structures. And again, don't be disappointed if you don't see those structures very well. It always depends on the sphenoid sinus pneumatization. So the more pneumatization, the better the orientation is. Again, make a U-shaped incision of the dura in order to spare the diaphragm and also preserve the intersphenoidal or the intercavernous sinus region, not to have a significant bleeding. If there is bleeding, elevate the upper body. Be very careful with packing, especially for the oculomotor nerve. You may use spongostan or any soft resorbable material that holds the bleeding very nice, but don't apply firm pressure inside the cavernous sinus. If you go towards anteriorly, if you want to resect the sphenoidal plane, which is the lamina terminalis approach, which you may need to go superior to the chiasm in case of a craniopharyngioma, make sure you expose the dura largely so you have enough access, and this would then also lead you to further anteriorly. But it's very important to know that on these two-dimensional structures, the skull base is elevating towards anteriorly, and here's the transition at the sellar diaphragm where most CSF leaks occur. Of course, if you want to go transplanar, you create a CSF leak yourself because you enter the intracranial space in order to remove the tumors. What you then see is the optic chiasm with the pituitary stalk. And here you see those tiny vessels that I was referring to earlier, and really pulling on them would damage them. And that would be, of course, detrimental for the pituitary function. You can also see into the anterior vessel complex, the communicating artery and the cerebral anterior arteries. And you can even go behind. This is, of course, not always easy to see onto the basilar top and the basilar artery. So this would be a very beautiful display once you went transplanar and exposed more of the structures than just the sellar. In a total dissection, what you can see is the pituitary gland with its pituitary stalk, the infundibulum. You see the chiasm running anterior to the pituitary stalk, and very importantly, the free parts of the carotid artery and its siphon, the paraclinoid artery, which is the closest towards medial and towards the sellar space, the parasellar carotid and the paraclival carotid artery. Inferiorly to the sellar and to the sellar turcica, you can expose the clivus, you reach the posterior cranial fossa with the pons. You can even go to dissect interpontine tumors, which we did just recently, but be careful, the basilar artery is not always in the midline, but it is in close proximity there, and this should of course not be harmed at all. The structures beyond are, of course, the floor of the third ventricle, the mammillary bodies further posterior and up, basilar artery, the whole optic tract, the Liliequist membrane that leads you into the third ventricle, and also then the posterior cerebellar arteries. But it's very beautiful if you try that on a cadaver dissection to really see what exposure you can achieve with an endoscopic approach. I'm coming to the end of the presentation. I could talk for the whole evening, but I don't want to take time from my colleagues. Just as a marker of what you see when you go further anteriorly, here you have the anterior ethmoidal arteries, which you may cauterize in order to take away all the bone of the cribriform plate of the olfactory region, and you see gyrus rectus and the olfactory bulbs running posteriorly, anteriorly. So if you had a meningioma in the olfactory tract region, that would be the approach, and that would be the nice exposure of the anterior part of the skull base. And here you really have to beware of taking care of the ethmoidal arteries and cauterize them. Of course, you can go into the pterygopalatine fossa. You see so much words. Please don't go through all of them, but try to memorize the confinements of the pterygopalatine fossa, especially the greater palatine and descending palatine arteries and nerves, because the pterygopalatine fossa is your gateway towards laterally, towards the infratemporal fossa, with its important structures, the sphenopalatine artery, the greater palatine nerve, V2 running then into the infraorbital nerve, the maxillary artery, and the communicating artery with the middle meningeal artery. This is then the way towards the lateral skull base from an anterior route via transnasal approaches. But again, this is for advanced approaches. I just wanted, for the sake of completeness, to show you that there is more than just the sella and the transplanum and the anterior skull base approach. To summarize, memorize the important structures, the medial opticocarotid recess and the lateral opticocarotid recess, because those structures nicely show you the position of the carotid artery and the optic nerve, where you of course don't want to run into that. And also make sure to respect the diaphragm unless you want to go supracellularly, because this is a very thin structure inserting next to the medial clinal process. You cause a CSF leak if you run into there. And of course, if you do expanded approaches, those CSF leaks are iatrogenically. No matter what approach you take, as you heard before, learn the anatomy, learn the CT, correlate the anatomy to your CT imaging. And at the end of the day, the best approach is always the team approach. And with that, I want to thank also my team, Dr. Gellner, Professor Mokri, and of course, Professor Stamberger, who will always be remembered in our team. And I want to thank you for your attention. Thank you very much.
Thank you.
Thank you very much for your great presentation. I think we are going to move to the next one, the presentation by Professor Berto Maroldi about radiological anatomy.
Yes, welcome to all of you. And my colleagues already provided a lot of things about the anatomy. I think I will try to give you some ideas about the anatomy from the radiological point of view, taking care of all the structures or some of the structures that are close to the interface of the skull base, where not the maxillary, but the frontal sinus, the ethmoidal complex, and the sphenoid sinus are in direct connection, in direct relationship with the anterior skull base floor. We know that paranasal sinuses, there are 4 cavities, and it is important to remember the difference between the anterior ethmoidal complex and the posterior ethmoidal complex from the perspective of the drainage, because in the anterior ethmoidal complex, which is comprising also the frontal sinus recess, the drainage will be in the middle meatus along with the maxillary sinus, whereas the superior meatus will be the area where the posterior ethmoid cells and the sphenoid sinus will drain. The separation between the two structures can be identified either in the axial plane, but also in the coronal plane. And it is realized by the ground lamella, the lamella that attaches to the lateral wall of the nasal cavity, separating the posterior from the anterior complex, where you see the ethmoid bulla, the hiatus semilunaris, the frontal sinus, the ostium, the beak of the frontal bone, the frontal recess, in front of it pneumatization, which is the agar cell, and then the area of the hiatus semilunaris, the horizontal portion of the uncinate process. The anatomy can be very different from one side compared to the other side, and then posteriorly, we see that we have the posterior myoid cells, the superior turbinate, and the sphenoid sinus. Well, that is the difference, and the difference is important from the point of view of the access, because you know that there are 5 doors already mentioned, for example, a transethmoidal approach to the sphenoid sinus, and you see that from the right side of the same patient and the left side, there are differences in the development of the different part of the anterior and of the posterior ethmoid. You're also able, in this case, to detect the channel of the anterior ethmoidal artery, in this case, far from the floor of the anterior skull base, because it is running in a part of the lamella. Therefore, it is 3-4 millimeters below the level. Whereas this pneumatization of the channel is very seldom detected for the posterior ethmoidal artery, apart for the Asiatic population. Well, the frontal sinus is very important. So this type of image has been acquired with the cone beam CT. Again, we are moving from the midline to the lateral aspect of the nasal cavity, being able to see the posterior ethmoidal artery always in front of the anterior wall of the sphenoid sinus, the optic canal, the pneumatization of the anterior clinoid process, and the trumpet appearance, which is larger in front than the posterior part of the Vidian canal on one side, and then a few millimeters moving in the lateral direction. In the midline, for example, the cone beam with 200 microns resolution is being able to demonstrate all those tiny channels that provide a passage for the olfactory fila from the bulb inside the olfactory epithelium. And this can be recognized with this type of imaging. And of course, in front of this, there is the crista galli. This is a partition, an horizontal partition inside the sphenoid sinus. It should always be taken care of this because it could identify a pneumatization, an excessive pneumatization of the posterior ethmoidal cells. Another point, which is a danger fact for the endonasal surgery, is related to the proximity of a couple of vessels, more frequently the mediorbital frontal artery, the MOFA, and then a little bit far from this, the frontopolar artery. Therefore, if meningioma, like Valentin was suggesting before, as a target for a transcribiform approach, you know that it could be useful to have an arterial phase with CT in order to rule out the close relationship of this artery with those structures. I already mentioned the possibility of reducing the dose, the exposure dose in the X-ray beam for the assessment of the skull base and the paranasal sinuses using cone beam. There are several types, sitting or standing, and then supine. Of course, sitting or standing, you can have more movement of the patient. And the advantage is related to the exposure, which is definitely lower with the cone beam approach, even if you are using high resolution or a very small field of view, and it is approximately at least 3 times lower than the one that you deliver with CT. Other key aspects to be mentioned when you are evaluating the sphenoid sinus is the possible presence of septa that are attaching, like in this case, on the sinus, on the sinusal wall where there is the internal carotid artery on both sides, and this should be mentioned. The pneumatization of the sphenoid sinus is really variable. In this case, the posterior wall of the sella turcica has been pneumatized, and you see that the pneumatization on the left side is reaching the anterior clinoid process on the other side. The second branch of the maxillary nerve, a groove, and then a small channel inside an extensive pneumatized sphenoid sinus on both sides. There are classifications that are going to provide you this type of information. Remember, always you are checking this VR line running from the foramen rotundum to the Vidian canal. And close to this area, there is also the channel of the vaginal artery, which is this one that you can see. So foramen rotundum, Vidian canal, the channel for the vaginal artery is there. These structures can be very well detected, and then also in this case, the optic canal and the superior orbital fissure. Variation in the ossification and pneumatization of the clivus are very important when you are planning your surgery, and the Hamburger's classification should be very well known to provide this type of information. Back to the ethmoid area, this is as Clementina already pointed out, this is the most fragile structure in the body. Maybe the crura of the platina are similar. The horizontal and vertical part of the cribriform plate are there. And then you have one lamina, the central one, the intermediate one, which is the attachment of the middle turbinate to the area of the fovea ethmoidalis, and then the other vertical lamella is the lamina papyracea. From the maxillary sinus, the ostium, the infundibulum, will drain with the help of the cilia inside the area of the hiatus semilionaris, where also the drainage, in this case, of the frontal sinus could arrive at this level, and this area is the area of the middle meatus, as we already pointed out. Posteriorly, behind the area of the nipple, as suggested before, which is the channel for the anterior ethmoidal artery, you will have the superior turbinate, and then medial to this, close to the midline, there is the sphenoethmoidal recess. The floor of the orbit and the groove for the infraorbital artery, the mucosa in MRI that is showing the mucosa a little bit thickened, that permits you to identify the floor, the nerve, the inferior rectus, the medial rectus, the superior oblique, and then in between, you know very well, there is the passage of the anterior ethmoidal artery. So that is a very important point. There is, as I learned from the ENT surgeons, from Paolo Castelnuovo, a common vertical lamina for the turbinates that you can see there very well demonstrated. Hanging on this lamina are usually the middle turbinate and then the superior turbinate, but also the supreme turbinate. And this is a very important area because, as you know, it is the area of the olfactory cleft, and the common lamella does identify the area, and on above this there is actually the olfactory epithelium in the olfactory cleft, as you can see that it demonstrated in this figure. You can see the same anatomy also on the MRI. Therefore, the common lamella hanging area for the middle turbinate and the superior turbinate is there. So the vertical lamella of the middle with a paradoxical curve can be identified. The olfactory bulb is there. The olfactory cleft is this. The transverse and flat part is the olfactory stria at this level, in the tract, I mean, and the crista galli can be detected over there. Behind there is the nasopharynx, and therefore the choana will give passage to the instrument inside the nasopharynx when you are close to the inferior part of the nasal cavity, and the opening of the eustachian tube is there. I move up to show you the sphenopalatine foramen, an area which is shared by the pterygopalatine fossa, the opening of the Vidian canal, and the area of the sphenopalatine foramen. The nasolacrimal duct can be detected, and also the sac. Then the path of the bayonet course of the infraorbital nerve is this, from the groove for the maxillary nerve inside the pterygopalatine fossa, and then this is the direction. Middle turbinate, uncinate process, and this is the infundibulum. And behind, we can see the superior turbinate, the opening of the sphenoethmoidal recess, and the asymmetry of the sphenoid sinus. Therefore, uncinate process, the infundibulum, the sphenoethmoidal recess, and then this is the area of the superior meatus. The uncinate process is not a simple structure. As you can see, it's not straight at all. So that is the base, and this attachment is at the level of the nasolacrimal duct. And then you see that the course of this is a very unexpected course, can be oriented in a very variable manner. This is quite an important consideration, but because according to the attachment of the uncinate process, for example, on the left side, but also on the right side, the drainage from the frontal sinus will move medially to the uncinate, or it could be lateral to the uncinate, not in this case. So we have a box. We have a box divided into an anterior ethmoid, a posterior ethmoid complex. And inside this box, we have a critical structure, which is the running of the anterior ethmoidal artery that can be detected, as I already mentioned, and its orientation is from posterior to anterior with this path that you can see. The green arrow is pointing toward the posterior ethmoidal artery in the same patient. There is a cell that is pneumatizing on top of the channel of the anterior ethmoidal artery. Remember, always in between the superior oblique and the medial rectus. On both sides, there is a cell pneumatizing, usually supraorbital ethmoid cells pneumatizing, and therefore the course of this is not inside the skull base. Very rarely, the posterior one does present a similar pattern of course. The critical area is to reach with the instrument is, of course, the frontal sinus, the infundibulum, the foramen, the ostium, the beak, the crista galli, the recess, and then the ethmoid bulla, the opening of the maxillary sinus, and the nasal bones. This is moving from this one to the middle meatus means that we have to unravel the anatomy in that patient of the frontal recess. And one of the first structures we are going to discuss is the Aschgar-Nazi cell or its variants, because according to the attachment of the uncinate process and the presence of Aschgar-Nazi cell or other variants like the supra-Aschgar-Nazi cell and the super-Aschgar-Nazi frontal cell, or the presence of a frontal septal cell, the drainage will be different. You see that in this synthesis, we have the different cells above the lacrimal sac. We have the supraagar cell and the supraagar frontal cell. In this case, the attachment is on the lamina papyracea at the interface with the frontal sinus, and the drainage will be medial to the uncinate process. The ostium, therefore, will be located in that direction. The opposite, when we have the attachment, like in this situation, medially, therefore, the drainage will be medial to the uncinate process. And this means breaking different eggs to reach that area. So we have several possible demonstrations of the variability of this type of attachment and the variability of the pneumatization of these structures. Well, we have to be very careful when we see something that we assume to be a balloon, because we are cutting structures with a section that can be differently oriented in the space. For example, we could call this, and originally we called this pneumatization of the uncinate process on the left side, which is not at all a reality, because these structures is actually simple, the bending of the uncinate process, and therefore the bending with the intersection in the coronal plate will give you it's a recess. It's not a balloon. It's simple recess in which the walls are simultaneously identified at that level, and we call this recess the Agar-Nazi cell, but actually this is a recess where the ethmoid infundibulum will arrive, and this is the path of the drainage. Therefore, the imaging techniques that we can use are the CT and cone beam CT. MRI is I will say, is very important for the direct demonstration of other structures, linear branches running along fissures, fossa, foramina, or fluid. Therefore, when you plan a surgical approach to the skull base using this, it is important to know, as we already mentioned, the opening of the Eustachian tube and all the structures that are behind the medial and lateral lamina of the pterygoid plate, because unraveling those, you know that you will have the medial pterygoid muscle, the levator palatini muscle, the Eustachian tube, the tensor palatini, the levator palatini, and so on. Structures that can be identified, for example, in this case, because the lateral pterygoid, the three branches of the V3 can be detected, and then all the structures that are belonging to the intracranial area. So stay close to the cavernous sinus, as Valentin already mentioned. With the CT, we are able to see the posterior ethmoid complex, on right and the left, the two sphenoid sinuses, the hypophysis, the carotid artery inside the cavernous sinus, and then the drainage, venous drainage of the cavernous sinus inside the superior petrosal sinus. Moving from this to the right and left side in the parasagittal reconstruction, optic nerve, the sphenoid sinus filled by mucus, the C3, C4, and C5 outside the diaphragm of the carotid artery, the anterior clinoid process, the superior petrosal sinus, and then on the other side, we can see all these structures, but also the essence of the bone at the level of the sphenoid sinus wall. That is a key point. The foramen lacerum is this area, a gap. With MRI, the same structure can be identified. First of all, on cell, a superior ethmoid cell, with the optic nerve that is directly close to that area. As you can see, the bone cannot be demonstrated, but all the other structures can be very well detected in even the third nerve inside the cavernous sinus. The optic nerve, the chiasm are there. If I move a little bit behind with the coronal plane, I can detect the carotid artery. I can detect the sixth nerve, and then, excuse me, yes, this is the sixth, the third, and the third, the fourth, the V1 and V2 inside the double lining of the dura at that level. And then this enhancement is the one of the venous composition of the plexus. This is a benign tumor at the level of V3. The chiasm is that. And this is quite an important ability of MRI to analyze the intracranial content. Therefore, my last slide will be dedicated to the integration of MRI and CT. In this case, you can easily understand that we are dealing with intracranial idiopathic hypertension with remodeling of the sella turcica and resorption of the anterior cranial fossa floor that is detected also on the coronal plane on CT. No bone is detected on the left side. On this side, but also on the right, you can see that T2 weighted sequence is showing fluid running down, running at the level of the superior ethmoidal recess on the left side. And then you have a fluid air level on the left. And if you move to a sequence that the neurosurgeons, I'm sure, know very well, which is the flare, where the CSF becomes black, you see that also this signal becomes black, therefore signaling that we are dealing with the CSF fluid. And this is the area that should be repaired, left, but I think also the right side. To sum up, cone beam CT will provide a lower dose, and low dose MDC will also give a low dose, but always a little bit higher than the cone beam CT, which is the technique able also to delineate the individual anatomy of each patient. Every time the whole 3D volume is acquired on cone beam CT or CT, it should be examined on 3 planes. And EMA can be very useful in a specific situation. Thank you.
Thank you very much for your excellent presentation. I have learned really a lot. Are there any questions from the audience to any of the panelists? You can type them in Q&A sessions or just raise your hand.
I apologize, but I didn't realize that I spent so much time.
We were so interested in your presentation that
thank you.
We also didn't notice this. I see that there is one raised hand.
It's me.
Oh, that's you.
Yeah.
May I ask you, Roberto, it was very interesting that and we did a lot of reconstructions and segmentations to really get more insight on the airflow and outflow tracts. Is there not at all a pneumatized uncinate process, or is there a pneumatized uncinate process with the variation of a kinked uncinate? Or would you say that the uncinate process is never pneumatized?
Well, the uncinate process is a lamina, and this lamina is not a closed lamina. I mean, it doesn't create a balloon, simply moves in the space and will attach with a single attachment or multiple attachment that we call several cells on top of, on top of, on top of. And then, of course, that image of the uncinate process pneumatized, if you simply look in the 3D, in the axial and coronal and sagittal, you realize that it's a bending. It is different from the pneumatization in the concha bullosa, because that is a closed or semi-closed structure.
Does the same apply to concha bullosa? That's when middle turbinate is not actually a cell, but that it's also...
Well, concha bullosa should have an opening, because otherwise the air cannot go inside. So it's a quite completely closed structures, pneumatized, but it has somewhere a hole for the air to go inside, whereas the Leucian process is simply a lamina.
Thank you very much.
Welcome.
There is a question from the audience whether the presentation will be available online. Yes, it will be. All of the webinars from ERS Junior Series are available online. So follow our LinkedIn or Facebook page, and you will receive the link.
And thank you for having me with unions, because I'm not, but it is really amazing. Very good, very nice presentation, good to the point.
Thank you very much.
Thank you.
And thanks to all the panelists, and thanks to all the listeners for joining us at this late hour on Thursday evening. I think that there is, I don't see any questions anymore. So yeah, thank you and enjoy your evenings.
Thanks to everybody.
Bye-bye. Thank you.
Take care. Have a nice evening. Bye.
Thank you.